Welcome to the Explainer. Today, we're doing something a little different. We're putting you in the hot seat for a high-stakes general surgery board exam. You're going to walk through a critical case, and you're going to have to make the life or death decisions as they happen. You ready? Let's begin. All right, just take a deep breath. Picture this. You're sitting in front of the board, the examiners are staring you down, and they're about to give you your case. Your entire consultant career is basically on the line here. The scenario starts right now. Okay, here's your patient. He's a 50-year-old man, and let me tell you, he is crashing hard. He's got horrible pain, he's turning blue, he's breathing way too fast, and he's totally confused. This guy is right on the edge of disaster, and he's just been handed to you. So here's our roadmap for the case. We're going to start with that chaotic arrival in the ER, work our way through some really tricky diagnostic puzzles, and then end up with the critical decisions you'll have to make in the operating room. Okay, let's dive right in. The patient is in front of you. The clock has officially started. Every single second counts here. How you manage these first few minutes is going to set the entire course for whether this patient lives or dies. The lead examiner leans forward, looks you right in the eye, and asks that first all-important question. They want to see how you think under pressure. They want to see your priorities. What do you do first? So the key here is to just ignore all the chaos and be systematic. You go straight to the ABCs. First, airway. Secure it and get him on oxygen. Then, breathing, circulation. You get 2 big IVs in, start pumping in fluids to fight the shock. And you draw a full set of bloods. And of course, you get a full set of vitals and a Foley catheter in so you can track his fluid response second by second. Okay, so your initial moves stabilized him just enough to get him to the ICU and through a CT scanner. Now, this slide gives you a much clearer and, frankly, scarier picture. He's on a ventilator, he needs powerful drugs, inotropes, just to keep his blood pressure up, and his kidneys have basically stopped working. And the CT scan, it reveals the cause of this whole catastrophe: severe necrotizing pancreatitis. His pancreas is literally eating itself. Well, the next problem doesn't take long to show up. You've poured 6 liters of fluid into this guy, but his urine output is still next to nothing. And that, my friend, is a huge red flag. His kidneys are shutting down, and you have got to figure out why, like yesterday. And this is a classic exam question, right? The examiner is testing your clinical reasoning. In a patient this sick, a bunch of different things could be causing his kidneys to fail. They want to hear you think through the possibilities out loud. And this is pretty much the list you should be rattling off. Is it the sepsis from his pancreas? Maybe it's the dye from the CT scan? Is it possible he's still in shock despite all that fluid? Could it be one of the drugs we're giving him? Or could it be something way more dangerous, something lurking inside his abdomen? You have to have abdominal compartment syndrome on that list. And right as you're thinking through all these possibilities, the situation just completely goes off a cliff. The patient starts deteriorating fast, and it forces you to stop guessing and pinpoint the one true cause. This right here is the game-changing update. He's gone from making a tiny bit of urine to making absolutely no urine. He's anuric, and at the same time, the ventilator starts screaming. It's getting really hard to push air into his lungs. It's like his whole body is fighting back. The question is, why? So with this new dramatic information, the kidneys are dead, the lungs are failing, the examiner looks at you. They're not looking for a list anymore. They expect a single, definitive answer. What is the one thing that ties all of this together? In the diagnosis is abdominal compartment syndrome. All that fluid you poured in, combined with the massive swelling from the pancreatitis, has turned his belly into a pressure cooker. It's literally crushing his kidneys, squeezing the veins so blood can't get back to the heart, and pushing up on his diaphragm so his lungs can't expand. A brilliant diagnosis, but you know the examiner isn't going to let you off that easy. You have a very strong suspicion, but in surgery, you need cold, hard proof before you cut. So how do you measure that pressure? You confirm it by measuring the pressure inside his abdomen, which you can actually do through his bladder catheter. And the number comes back 24 millimeters of mercury. To put that in perspective, normal is less than 5. This is off the charts. You've just confirmed severe, life-threatening abdominal compartment syndrome. He's in very, very deep trouble. Okay, there is absolutely no time to waste. You have a confirmed diagnosis that is actively killing your patient minute by minute. All the medical stuff has failed. This is a surgical emergency, and you have to act. The examiner's question now is very direct.
You've got the diagnosis, you've got the proof. What is the definitive, life-saving thing you are going to do right now? The only correct answer is to get him to the operating room immediately. You perform what's called a decompressive laparotomy. You make a long incision down the middle, and the second you open that last layer, his swollen insides just bulge out, and you can almost hear the pressure being released. Of course, there's no way you can close the abdomen, so you put on a special temporary closure device to keep everything safe.
And your bold move works. The patient's breathing gets better, his kidneys start making urine again, he stabilizes. But your job is not done. 4 days later, you take him back to the operating room to try and close him up for good, and that's when you run into one last major problem. So the ideal plan was simple. Just bring the strong layers of the abdominal wall, the fascia, back together and stitch them up. But the reality is totally different. The fascia has pulled way back to the sides, and there's this massive gap in the middle. If you tried to yank it all together, it would just create insane tension, and you'd give him compartment syndrome all over again.
So the examiners want to see your surgical creativity now. Closing a complex open abdomen like this takes real judgment and a knowledge of some advanced techniques. What's in your toolbox? What can you do for this guy?
And so you lay out the options, because there are a few, each with pros and cons. You could just close the skin over the top and accept that he'll have a giant hernia you'll have to fix later. You could try to slowly pull the fascia together over a few operations. You could bridge that gap with a piece of synthetic or biologic mesh. Or you could do a more complex operation called a component separation, where you make some clever cuts to let the muscles slide to the middle for a tension-free closure. So after this whole terrifying ordeal, the real takeaway is this. Anytime you have a critically ill patient in the ICU with multiple organs failing, especially after you've given them tons of fluid, you have to ask yourself, what about the abdomen? What's the pressure inside that forgotten compartment? Because not checking, not even thinking about it, can be a fatal mistake.